where I work now.
I know. It is just like a chill room.
It's not bad.
No, listen, I got to tell you, it does not suck. So, I mean, for me, you were someone I was looking forward to talking to. And what I try to do on every show is I love to listen and hear the mindfulness hack that you used to survive 2020. I mean, we all, had to maybe up our reflection or self-reflection game because there was a lot of quiet time. And I thought that would be a good place, I think, to dig in, if that's okay, and just learn about you and how did you stay mentally strong?
I guess the question presupposes that I did stay mentally strong.
Okay.
So I would say, 2020 this is no surprise to anybody. Everybody's in the same boat. Really a challenging environment, both personally and professionally. Yep. I am in some ways very fortunate, very privileged in that I have a job that was stable throughout the pandemic. I work for Seattle Children's Hospital. And just at the outset, I do not speak for Seattle Children's Hospital. I am an employee of Seattle Children's Hospital, but I am not a spokesman for them. Everything here is my own opinion. So, I am a data science manager at Seattle Children's Hospital. And in some ways, early on in 2020, when the pandemic hit and we declared our emergency, that was kind of a blessing in disguise because I had a lot of work to do. We suddenly had we had an emergency operations command center. We had to get up and running with all of the dashboards and data flows that the clinical leaders needed to do their job. And then all of the reporting to, at least 4 and maybe half a dozen different regulatory environments, city, county, state, federal, making sure that they got the data that they needed from us. And so I and my team were working 100-hour weeks for the first couple of weeks of the pandemics. And that was yes, it was really challenging, but it was a blessing in disguise that I didn't have a lot of time to think about what was happening, right? Yeah. I just had to do. But then, of course, as the pandemic wore on and that work had been completed, I was in the same boat as everybody else. I had to find a way to shift a team of data scientists and data engineers from on-site work to home work, including myself. I work from home now, and that looks like it's basically permanent feature of my professional life as long as I'm in the position that I'm in. And my partner also, she works from home now. So we had to find ways in the house to both be able to have our own offices. And, that's why I'm in the basement and she has a small alcove upstairs. Again, very privileged that we both have jobs, that we have a space that's large enough for that. I recognize not everybody's in that situation. And then it was a matter of just kind of finding a way to adjust to the new normal. One of the things that we did when you start talking about the mindfulness aspect is that we decided to keep a commute. So every morning when we get up, we make coffee and then we walk a mile together and we chat about, whatever's coming up for the day. And then we come home and immediately start our work. And so having that 25-minute commute in the morning that is literally just, we walk a half a mile down the street to a vista point where we can see Mount Rainier on the horizon and then back. And, and that's kind of centering for the day to try to get ourselves into a framework and then work throughout the day and then take the day, and then actually have an end point of the day in the afternoon when it's time to finish work. So that's been really useful, and maintaining that sort of physical activity. I used to bike to work from home. It was about a 4-mile bike, which works out to being about the same, sort of 20 minutes. And so having that has been really helpful in keeping the routine settled and keeping the mind focused and separating home and work life.
Yeah, I think that is what I've been hearing is everyone has found their way. And I'm just always curious to see how people have been able to find that way to that new normal and just what I could learn and how I could share. So for me, part of the reason we started the podcast or even this community was when COVID hit. I'm in San Francisco. Now I'm part of the San Francisco to Miami exodus. So I've done the exodus. But in San Francisco, we were in shelter in place starting February. And March, I'm crying. And I said, the world got me down. I mean, it's just sad, really sad. I called my mentor. My mentor is like, you should bring a community together. And we put together this great data community. And the goal was just to give hugs, just hang out and give hugs. It's not really like Zoom parties type hubs, just like, let's just get to meet. So many people are introverts. And what I learned through this for me and some of the outputs was, one, I got back to journaling, my daily journaling. So to me, I'm happy I got back there. That's the first thing. And I've always been about self-reflection and mindfulness. And I really was able to up my game. I was really able to maybe dig into a few things and do a little bit more and try to help people in my team and who I mentor about the importance of either journaling or mentoring or mindfulness. So
yeah, my partner and I are very outdoorsy as well. And I have started doing things like, taking one day off a month to go and climb a mountain, and here in Seattle, of course, if in San Francisco, similar, it's an hour drive to a trailhead to being in deep wilderness and really being able to get away from everything that's crowded, spend some time at peace and in nature.
Yeah.
And we've done a lot of that this year. I think I climbed 6 mountains this year.
I think you're going to look back at this and just feel like you didn't do enough. I mean, I love that.
Mm-hmm.
I mean, I'm trying to really maximize every day because of this. This is a weird spot where everybody is home, traffic is light, and everyone's dealing with the same type of environment. The remote work or work from home is also, I think, different right now in the sense for me and people I speak with. It used to be, hey, I'm working from home today, but that means you're doing errands and meeting people and going and seeing friends. There's nowhere to go, at least for me. People I speak to, like, working from home, what are you doing? Like, right. Just work. Like, I don't go to a public gym, but I can work out, right? I'm not meeting a friend for coffee because I'm still not comfortable. It's a me thing. Right. And so as much as people like, I love working from home, they're not distracted yet. Let's see how they work from home when there really are true distractions where.
Yeah, it's going to be interesting to see how it shifts.
Yeah. So now Seattle, one of the first places for the outbreak, lots going on there, and not asking you to talk on behalf of the hospital, but just you saw things that most people didn't. You experienced things that most people didn't, or we would just watch on TV. Do you feel blessed? Did you leave days and just cry? I mean, because you were on not you person, but your state was really front line on a lot of what was going on in February and March.
Yeah, I mean, it was really, really scary. It was hard to process a lot of the time. Of course, I work at a children's hospital, and children are not that affected by this disease. Again, I am not a physician, so don't take any of this as med advice or whatever. But it seems to me, as someone who pays a lot of attention to the science behind this, insofar as I am capable of that children are not as affected by this. Certainly, we're not seeing the death rate that we see in the older populations. And as a result, what my hospital saw is what many children's hospitals saw, which is we actually saw our censuses go way down because people weren't going to the doctor. They weren't going out.
Got it.
Sports. They weren't, so we didn't have injuries.
It's a good point. That's a good point.
Yeah, exactly.
So injuries. So it's like, kids playing, whatever, playing, just in general playing.
Right. And then, of course, for better or worse, some people are afraid of getting sick at the hospital.
Yes.
So, if your kid has the sniffles, you were, I think, less likely to bring them to the hospital this year.
Interesting.
And so the result was that we had much lower census than normal. And that was a little scary from us, because that has financial consequences for the hospital. And there were those of us who were afraid that, we see other people being laid off. Is that going to industry as well? Is that going to hit our hospital as well? And our hospital really, I was so proud of the commitment that they made. Our senior leadership all took big pay cuts in order to make sure that they didn't have to make layoffs. And so I have been really proud of the way that our leadership handled the situation, and really proud of the way the hospital was able to respond. They established like an employee emergency assistance fund, and
really nice.
That, even though we weren't losing our jobs at the hospital, people's spouses could be, things like that. So they actually really stepped up and made a lot of what I think are genuinely valuable efforts at supporting people through the institution, even though it was costing them a lot of money. So that was nice to see.
Those are the companies that win.
Yeah.
We all have friends that have salary reductions or been laid off. Not a lot of jobs out there. I mean, it seems like there's a lot of jobs, but there's a lot of people applying for those jobs. So the empathy that we need to give to not only our employee, but you're right, their home is maybe in a state of panic.
Yeah.
And we need them to still be able to produce, or else they might lose their job. So I think the empathetic manager also wins in this environment.
I hope so. The thing that I decided as a manager, I have 6 direct reports, was to just immediately decide that I was not going to worry about people missing meetings because they were homeschooling their kids, or, like, all I care about as a manager at the end of the day is, are we able to deliver the mission critical things that we need to deliver to the organization in order to make sure that we can meet our mission of caring for sick children, right? And if that means that for you're going to, educate your own children during the day, and you're going to work from 4 p.m. to midnight because that's what works for you, that's not a situation I would personally want to be in. But if that's what works for you, then by all means do that, and I'll work around. And so I think, just the expectation of everybody is doing their best, right? I'm fortunate to work in a department for an institution where everybody shows up wanting to do the job that they're there to do, right? The people are invested in our institutional mission. And my job as a manager, a lot of the time, is just to get out of their way, let them do it in a way that works for them, and make sure that I'm aligning projects with the organization's needs and goals. And if I can do that, then being accommodating to the people that report to me is going to make them perform better, not worse.
Yep. I'm with you. And not only are you someone who believes in empathy and mindfulness, you also have a belief system in ethics. So
I do.
So let's, and I think I don't know if there is a correlation there, or just being human and having awareness that if you have true reflection and mindfulness, I think you understand where ethics are. We might not agree exactly where the line is.
Sure.
Not you and I. I'm just saying people might not agree. So tell me about the ethics paper you're writing and working on.
So we actually just published a paper. It's called The Case for Information Fiduciaries. And stole that word generally from the sort of finance world. But a fiduciary is someone who is required to act in the best interests of the person that they represent, rather than in their own best interests. And so we just published the paper in the Journal of the American Medical Informatics Association.
Congratulations. Getting it published. Congratulations, by the way.
Thank you very much. It was very fun. And the crux of the paper is that, a lot of your audience may not be familiar with medical research, but there are a lot of regulatory instruments that are used to protect patients who participate in medical research and clinical trials and things like that.
Okay.
And that's generally done through what we call an institutional review board, which is a body that is put together at hospitals or universities, places that do medical research. And they are responsible for ensuring that the research that is done is as safe as possible and has the right number of participants. You're not doing underpowered studies or overpowered studies, and that all of the principles of ethical and beneficent medical research are adhered to. And that goes back to a founding document called the Belmont Report, which is worth reading if you're interested in medical research ethics. But that medical research should be founded around justice, beneficence, and respect for persons. And the IRBs are responsible not only for protecting the actual subjects themselves, but also their data.
Okay.
And the privacy of their data, et cetera, and their consent to be part of the study, their consent to have the data used as part of the study, things like that. And there are similar regulatory bodies and environments that govern things like the development of medical devices, algorithms as a medical device, et cetera, et cetera. But there is no regulatory framework for the use of patient data for internal data products. So, for example, for me, when my team builds a dashboard that the public is never going to see, the patients are never going to see, it's only going to be used by, say, nursing leadership and physician leadership to make decisions about patient flow within the hospital. There is absolutely no regulatory framework for the use of that data. And we might think, well, so what? It's not going to be published. It's not going to be sent out. Why does it matter? It's done with the intent of making sure we get the right kid in the right bed at the right time. And that's all true. And I don't think that there needs to be an extensive regulatory environment over it. but there are ethical considerations that still matter. So as an example, consider a situation where this happens in almost every hospital in America, where some rooms are single rooms and some rooms are double rooms. And you put a patient in a single room if you can, but when census pressure is high, you put patients into double rooms in order to maximize your space. Who gets put in double rooms is not an ethically transparent decision. And so if you simply use the data that you have about the patients to say, we need to look at putting patients into single versus double rooms today, you may be injecting healthcare disparities into this environment in a way that could be avoided if you were careful. And so, you very frequently hospitals will look at data like that and they will discover, oh, it turns out we put African-American patients in double rooms 3 times as often as we put white patients in double rooms. And that can result in a disparity. Patients in double rooms may not sleep as well, which can affect their outcomes. Your nursing, because you may be short on nursing staff, may be by the room instead of by the patient. And so you result in providing patients in double rooms that have this disparity with less nursing care, et cetera, et cetera. So those decisions, they have ethical implications, they have equity implications, and they have outcome implications. It's not only that someone may be treated differently, but that their actual care and recovery may be worse because of the equity decisions that are made or not made. And so, nobody thinks that African-American patients are double roomed more often, for example, because there's some racist in a flow pool who's making that decision. It's either an artifact of other data decisions that are made, like saying, okay, well, we're going to double room people with sickle cell, and that has a correlation, a confounding relationship with patient race, or it's a subtle implicit bias that people just aren't aware that they have. And so when those things get codified into algorithms, patient care can suffer and disparities can increase. And so what we did at Seattle Children's and what we published was a checklist, essentially, that whenever we're starting an internal data project, we look at this checklist and it has a series of questions that ask about things like, if your own data was going to be used this way, would you be concerned about it? If your child's data was going to be used this way, would you be concerned about it? Do you believe that there's a way that this data could result in biased outcomes for marginalized groups? And questions like that, they're very simple, very straightforward. Using the checklist only takes about 5 minutes, but it causes people to think about things that they might not otherwise think about and helps identify opportunities where disparities and equity issues could be injected into an otherwise straightforward data product that would result in harm.
There's a lot there, right? The first part is the data part. It's interesting we're talking about double rooms versus marquee donors. Mm-hmm. The marquee donor will get their own room on their own floor. So we'll check that box, right? Of you write a check. Where's the data?
That's interesting. From? VIP healthcare is not always better. And sometimes it is noticeably worse. But you're right. In the industry in general, that can be a problem.
So we're not going to talk about that corner case. So the data that you're talking about, is that the intake form that you fill out when you get to the hospital? What do you hear? What's your name? Where are you getting that? The core first part of the data of the diagnosis, the age, the name, the injury, or
well, that will depend on how you arrive at the hospital.
Okay, that's what I'm saying. So that's the source of truth right now. It's something in an intake form that is the source of truth.
So there again, it depends how you arrive at the hospital. If you arrive at the emergency department, then yes, you see an intake nurse who records your information, your reason for visit, et cetera, and puts it into a new record in the electronic medical record, right? But if you are arriving at the hospital through the surgery center, then chances are you are having a scheduled, what we call elective surgery. Elective doesn't mean unnecessary. It just means that you can schedule it as an emergency surgery. Like a heart transplant can be an elective surgery.
These are kind of the intakes of how the internal hospital is trying to figure out their they're modeling is they have to start somewhere. So that's the data source.
Exactly.
Yep.
And so that data, if you're coming into the surgery center, or if you're a direct admission into the inpatient wards from outside the hospital, your information may be just electronically transmitted from your primary care physician, for example. And nobody's actually writing it down at the beginning because your primary care physician wrote it down 2 years ago when the first time you saw that.
Yeah. I mean, it's the way you talk about this, it's a good and a bad conversation. It's a good conversation because we're talking about the uses of data that we might not have thought about. So I like that type of conversation. The challenge is I don't know where the line is for the regulation. I don't.
Sure.
So the phone apps on apps now, when you have an app, there's kind of three choices. Can we monitor you when the app is off? Can we monitor you when the app is on, or can we not monitor you? So the way we're talking about this and the way I've jumped visually is like, great, when I go to the hospital, I have to sign, am I able to share? Can the doctor call your wife, husband, partner? Who do you want? And can we use your information to improve our own process? Right. Because that's what we want to do. And I'm all for that. To me, and I was on another podcast, I'm all for open data. I'm all for sharing data. For me, if I give you my data, my always assumption is I will get more value out of it. But I also took that in another podcast saying, not only do I share that data, I'm also a donor. So for me, I just wonder if you can extend that line of the people that say, take it and also take my body parts. Right?
Yeah, there's so much to talk about there. So first of all, the regulatory environment is something called HIPAA that you may have heard of. It's called the Health Information Portability and Accountability Act. And that governs how hospitals can share your data. That doesn't bind the patient. It binds the hospital and the physician and people like me who use healthcare data. And so that restricts how we can share it in sometimes ways that feel onerous, especially when you're trying to develop things that say predictive analytics that can make predictions that are useful for other patients. And there are things like waivers of informed consent that you can get in research in order to use someone's de-identified data in order to understand how their information may support predictive analytics and other things. With regard to open data, this is one of the situations where there are good ethical arguments on both sides of the debate about open data, and you and I may not agree on where we stand on it. So I wrote another paper a few years ago. This was published in the journal PLOS One. I can't remember the title of it off the top of my head, but fundamentally what it comes down to is a friend and I decided to do a study where we considered, does open data and the intention of researchers to use open data influence people's likelihood to participate in research? So
it's a great question.
You may
it's a great question.
Hey, my data, I want everybody to use my data. So if I know this research study is open data and that research study is closed data, I'm going to do the open data study because I want to help people. Whereas somebody else might say, hey, I just want my data to be used by these researchers for this thing that they told me about, and I don't want to share it because I don't like the privacy implications.
Both are right. I'm tracking. Yes. Yep. Great.
Perfectly rational.
And no matter how you wrote many years ago, it's still a valid hypothesis today. It's
exactly.
On.
So what we did a deceptive study, right? What we did was we did a pretend study. There was no real world study. There was just a consent form, but people didn't know that the consent form was the study. And we gave one consent form that said this study uses open data, and one consent form that said nothing about open data. It was just a standard consent form. And then we randomized people to which consent form they got for the study.
I love it.
Either consented or didn't consent. We said, congratulations, the study's over. Haha, we tricked you. And what we found was it made no difference whatsoever. And the reason that it made no difference whatsoever is that everybody consented to either form. And because it was electronic, we could see that nobody had even had time to read the form. The average person engaged with the form for like 2 to 5 seconds. And so what we did though was we then had a debrief survey that said, okay, the study's over. Here's what the study was about. What do you want to do? Do you want your data to be open or closed or et cetera? And what we found was a significant number of people who consented to the open data form, and that in the real world, in a real study, in a real consent form that said that they would have open data, they would have consented to it. And then when asked, are you comfortable with your data being shared post hoc? They said no. That wasn't everybody. I don't think it was even, I can't remember. It was a large number, but I don't think it was even half, but it was still a large number. And so what we have learned from this is that informed consent is certainly not informed because nobody read the consent form. And informed consent is also not consent because a significant number of people officially consented to something which they then, upon query, said that they did not consent to. And so, medical research has a problem, and data science has a problem with how much do we respect the subject's desire for the use of their data? It's a hard question.
I think there's a few things there, and I want to just keep going if that's okay.
Sure, go.
Right. So I think that study not only is valid, but I think what you've unlocked is you've done that in a intentional questionnaire form. We've all filled them out. There are a lot of really sharp UX, UI designers that play the same game on the apps. There is an exact timing of when to ask that question. Hey, can we link your accounts? No, not now, but they'll ask you again in 3 days.
Right.
And then sometimes you're right. You're on an app and you're just not paying attention. You just want to quickly sign up. Like there is a speed to sign up, whether it be your questionnaire or just an app. And maybe you don't realize where these things go or don't go. I think there is a real problem. Now, the opposite side to that is I don't know why some of these apps need all this information about me.
Right.
I don't know why an app that's about making this up, the weather, needs access to my photo reel.
Right.
So, I mean, like but it's almost like you're saying, can't hurt to ask. Can't hurt to ask. Like we might need the data someday.
Or we might be able to sell the data someday.
Correct. Where I am with your sector, I'm on the give all my data to researchers. And I do believe that, right? So if my blood type, if my age, if my pattern can help get to a cure, I want that data out there. I mean, I'm going to trust you that you're going to anonymize it. And I just don't know. I mean, I'm assuming you have, not you, but not you or your company. I'm just saying like, there's always bad actors, but I feel that, anything with clinical research, the more we can do, that's just for me. I like to do that. I don't have that same desire to give more data to certain apps that I don't think they overreach.
Sure, absolutely. But I also want to caution the conversation from the idea that, all medical research is always good, right? Some of the worst excrescences of ethics in human history have been done in the name of medical research. The Tuskegee syphilis study. That's where the Belmont report came from, was in response to that, right? I don't think that the people who were doing that study did it like with the intention of just twisting their mustache and being evil, right? They thought that they were getting important data and they just didn't care about the fact that they were killing people. So medical research does have as much of a need for rigorous ethics as any other industry.
And now that we're coming through, let's call it, there's a vaccine for COVID. We've got a couple early leaders in that, Pfizer and Moderna. If tomorrow you were called by the government or Fauci or somebody and said, okay, what 2 or 3 questions would you add to our research study, right? Because now people are getting vaccinated. We want to maybe look at it, and there might be the kids are going to be next, maybe in 10 months. What data point would you want to see as they start bringing back the data in to be smarter?
That's a really interesting question. I'm sure a virologist or an epidemiologist would be able to answer those questions really interestingly. For me, I would be very interested, and I've seen some of this data coming out. I don't think it's coming from official government sources, which means they're probably not the ones collecting it, but I can't recall off the top of my head. But I've seen some geolocation studies of where are people dying of COVID versus where are people being vaccinated for COVID. And surprise, surprise, there's a huge disparity. Far more persons of color are dying of COVID than white people, but far more white people are being vaccinated for COVID than persons of color. And so I would want things like zip code, Zip code is a good way of getting relatively fine-grained geographical data without identifying individuals.
I like that. Yep, I like that.
Although you do have to be careful because your sex, your birth date, your zip code uniquely identifies half the people in the United States.
Yeah. Oh, I did not realize that. Yeah. I like zip code. I think that's I wonder also if I was asked, that probably the one thing I'd probably want to add. I said, okay, what if Fauci called you and he's like, what else would you want to know? That's it. I never thought of asking that way. So what I'd want to know is, because there are so many, I would try to ask a question that would try to prove a conspiracy theory right or wrong. So, I would like to just know, like, did you have Thanksgiving with your family? Like,
oh, that's interesting. That would be.
I just want to know, like, just curiosity, because some states were like, nope, don't see your family for Thanksgiving, right? Some people did. So I don't know. Like, to me, I would be curious on how much of the bubble did you believe in? I would even ask, did you wear a mask or not? I'm not trying to get into a political conversation, but I would just be totally curious when I see the numbers coming back. I would just be like, let's just, I don't know.
Sure. And at the same time too, I don't think that data science can be apolitical, right? I think that everything in life is political. There's just a way to avoid politics in any aspect of life. And we have a choice if we are going to try to use data science to construct a better world, or if we're just going to
better story. I mean, that's where, it's a better world, a better story. Like, the worst story we could hear is, I never got COVID because I ate pineapples every day. Right. It's just like there'll be somebody out there that is going to be, selling some type of melon or some type of, I ate steak every day for a year and you'll die of something else. You didn't die of COVID, but
yeah. So, I mean, I think it would be useful to ask people things like, do you think that COVID is worse than the flu?
Yeah.
Or do you adhere to social distancing and personal protective equipment when you go out? Do you wash your hands when you come home? Asking questions like that and seeing if you could correlate to.
I would love that. I would love to do a study.
Vaccine acceptance.
They're probably going to do it, but are you going to shake hands? Like, to me, I'm okay never shaking hands again. To me, I never shook a hand. If the rest of my days I'm just doing elbows, I'm fine with that. I can't tell you how many times you know what the worst part of the shaking the hand is? And to everyone who's listening, the people that just give me triggers are people that shake my hand. They go, hey, oh, by the way, I'm just coming off of a cold. The people that do that, or the people that I have dinner with, they're like, oh, I'm glad I'm coming down with a cold. I'm like, you're not, like, I don't need to be around you. So I hope the one thing that comes out of this is just general. Like, if you're not feeling well, don't hug people. Don't shake people's hands. I'm not talking a COVID conversation, but has that happened to you where, like, someone shakes your hand, hugs you, and be like, oh, I'm just coming off with a cold. I'm like, thank you. I'm going hiking this weekend. It just sets me off.
Speaking of diseases other than COVID, the CDC published this week. So the average number of pediatric patients who die of the flu in a typical year is between about 150 and 200 nationwide.
1,000, right?
No, just total. 100 children who die of the flu every year.
Okay, got it. Sorry. It's a low number.
In America. This year, the flu season that we are currently going through, there has been one.
School's the petri dish. School is the super spreader.
School and then, people are actually masking. It's not 100%, but a lot of people wear masks. A lot of people are showing the distance. And this year has been one of the lightest flu seasons we have ever had because of it.
And that goes back in October, November. Oh, it's going to be the worst flu season ever. It's the hype machine. That's the other, we talked about earlier about what I did for mindfulness. I stayed off cable news. Like,
wow. Impressive.
I mean, it is, I don't know the answers to this, but there's a lot of I still get news. I still am informed, but you're right. I did not know that. And I don't watch news enough to know, but I don't get a sense that it's the lead story because it hasn't shown up on my news feed.
No, I never saw it in the news. I saw it because
know that.
healthcare data. So,
I mean, that's
and I work at a children's hospital.
right, like, and it makes sense, but I'm delighted by that. And unless I'm the doctor hospital that lost the child, that is just awful. Like, that's because that is just so sad to be that one. Man, this was cool hanging out with Eugene.
It's been a privilege.
So there are a few people in the healthcare sector that I would like to introduce you to. One is working on a clinical study. He was just on my show. He's at Anthem, and he's doing some cool stuff. He's in LA, so I think that's cool. He's on your coast, and some other people. But I think part of the reason why we build this community is also to the exhaust of it, to connect you with people you might have met at an event or a conference or something like that. And that's what we want to do, is build these connections. So you cool if I just like LinkedIn and connect you with people I think you would just enjoy just talking to?
I would love that.
Yeah, and I'm sure they'd want to hear more about the paper and stuff like that. I think there's something there, right?
Yeah.
So that's super cool. And we might end up doing maybe like a healthcare roundtable, because I've spoke to a few people about this. And it's just about a way to connect people, maybe 45 minutes, just how else can you meet thought leaders? You guys can pick the agenda. We'll just set the forum up. So we'll think about that.
I'd love that.
Yeah, that's cool. Well, listen, we're sponsored by Pandio, and we are so grateful for you hanging out with us, giving us extra time. We wanted to dig into a few places, and I didn't want to stop short. So thanks for being on the show. And we definitely want you to come back.
I would be happy to.